Hello, I'm Scott Ellis, and welcome to this presentation on planning for influenza season. We'll be going over the analysis which will address staffing shortages created by the tens of thousands of flu hospitalizations and deaths every year in the United States. Temporary staffing increases can help to mitigate the overall burden on the healthcare system, and this analysis proposes nationwide staffing levels and state staffing allocations based on seasonality, geography, annual trends, and vulnerable populations. So you can see in the chart below that over 40,000 Americans have died from the flu in each of the past 8 years. And while total nationwide deaths do not vary drastically from year to year, we can see that trends within a year can be quite different and unique. And so we'll click through the years. Let's click on 2010. And so we'll see in the charts to the right, the when do we need staffing and where do we need staffing map, that within a year, the trends can look very different. So the highlighted year here in the seasonality chart of 2010, you can see how different it is from all the other years that are faded out, the other 8 years that we've looked at. So that presents a very unique challenge, being that it's not extremely predictable. If it's varied a lot in the past, it could vary a lot in the future. And that goes for the time aspect and the seasonality here. And it also goes for the spatial geographic distribution state by state in the map below. So we can click to another year, 2012, and we saw all these colors change for almost every state. So the severity within the state is changing, and the severity over time within each year is changing as well. So that presents a challenge in predicting future staffing needs for the upcoming year. The rest of this presentation will cover each aspect of this challenge in detail, from the timing, the geographic distribution, to vulnerable populations, and finally to predicting staffing levels and allocations, all in order to mitigate the risk of the flu and ultimately to save lives. Starting off with, when do we need staff? Timing is one of the crucial factors in addressing the flu threat effectively. The first chart we see here is helpful in determining the average temporal distribution of flu severity. You can see that nationwide, total deaths peak in January-February with almost double the amount as the low point in July and August. So this trend line was developed from each of the past 8 years, and we can see that once again each year can vary drastically, and this is the average. The average across the last 8 years has this winter peak and the summer low. Regional trends follow a similar pattern without very significant differences between regions, at most only a couple weeks between the different regional peaks. This means that peak staffing will happen concurrently across the country. And we see that in the top right chart, the 4 census regions. You can see that they peak very close together. So that means our peak staffing will be pretty much happening at the same time across the country. And the bottom right chart shows states within the Midwest as an example of individual differences. Instead of following the rounded average pattern of the trend lines, states can have multiple peaks throughout the year. So we see within the Midwest, they tend to follow similar patterns, but they're not all exactly the same. And they do have multiple peaks within the year. Looks like January and March are peaks, and most states have a little bump in October. So this is all very helpful in the predicting of when staffing will be required in regions and individual states. On to where. Equally important as when to send out staff is where to send them. Flu severity not only changes significantly with time, but is drastically different between states. So this map is showing the total death percentage of the state population, which for the rest of the presentation we'll be calling the death rate from the flu. And in this map, the size of the circles represents the total population of the state. So we'll play through 2009 to 2017 and see how the geographic trends change over time and between the states. Starting in 2009, we have the highest death rate labeled, and it's New York. For the first few years, it stays in New York, the highest death rate. And now we see in Tennessee, it moves to Tennessee for a year and then finishes out the last few years in Hawaii. From the highest death rate from year to year, we get a sense of the spatial trends across time, as well as pointing out any outliers, which Hawaii seems to be an outlier. Most of the Western states have low to medium death rates, and then Hawaii is the highest for the last few years. We can also see these spatial trends in the central Midwest and South here, with much higher death rates than all surrounding regions. So it is essential to know where flu is likely to be most severe, as staff will need to be sent to those areas in higher numbers. One guiding question of this analysis dealt with how the vulnerable population, those 65 years and older, relates to the issue of staffing. It was hypothesized that if a state has a higher proportion of 65 or older people, then the relative number of deaths from the flu will be higher. So this hypothesis was proven to be true in testing, meaning that it's true that older people suffer more from the flu, but its correlation coefficient between the proportion of the older population and the death rate was weak. So we can see that in figure 1, this chart up here. It's plotting the 65 plus proportion of the state with the death rate of that state. And we see this line is the trend line. And if these variables were highly correlated, all these data points would be aligned closely around the trend line. In this case, it's not true. The correlation coefficient is 0.21 out of a maximum of 1. So that means it is a weak correlation. So this can be visualized further by highlighting one of the many states with large proportions of vulnerable populations that have low death rates. So for example, Vermont has a higher proportion of older people and still has a very low death rate. New Hampshire, same thing. Delaware, Montana, same thing. Idaho, very similar. So it's clear here that there must be other factors influencing a state's death rate other than the vulnerable population. It was found that a better correlation measure for death rates is the population of a state, total population. You can see in figure 2 down here that both total and 65 plus population data points of a state are closely aligned with the trend line. It's useful to note the outliers here, such as Florida, below the death rate trend line, but higher or older than average vulnerable population. And New York, we can see in figure 1, they have around the middle of the pack vulnerable population proportion, but very high death rate. And finally, Hawaii, it's our main outlier here, has a rapidly increasing death rate along with an increasing vulnerable population proportion. So the vulnerable populations are important to keep track of, but are not a main factor in predicting flu severity and staffing. In conclusion, we've talked about the why, the when, the where, and the who of influenza severity in the US, which gave us an overview of the trends of the problem. In order to arrive at actionable numbers for staffing in the upcoming flu season, flu severity was forecasted using a multiplicative model, which achieves greater seasonal accuracy with exponential smoothing based on the last 8 years of actual data. We forecasted 1 year into the future. The shading around the line represents the 95% confidence interval, which means that 95% of the actual results in the future should lie within that shaded region. The charts to the right assume a staffing ratio of 2 additional staff required for each flu death. This was an assumption made in order to show how the final staffing numbers can be arrived at. But the ratio should be determined based on further analysis of staffing requirements. First, in the top right chart, monthly nationwide staffing needs should be proportional to the forecasted total flu deaths. Based on the assumed staffing ratio of 2 additional staff per death, you can see that in January of 2018, 13,704 additional staff would be required. Next, the monthly state staffing allocations are determined from the nationwide staffing levels by multiplying the state's percent of the total flu deaths for each month. And so we see that the allocations come directly from the nationwide staffing levels based on the state's proportion of flu deaths forecasted. So for example, we can look at New York. In January of 2018, it's forecasted that New York would need 2,268 additional staff based on the assumption. So we could do this for each state for the entirety of the next year and see what the staffing requirements would be. So Colorado, January, 315 extra staff. So in addition to determining the accurate staffing ratios, which will be used to give the final numbers, next steps also include conducting in-depth temporal and spatial analyses at finer geographic levels of detail, down to the county level and also the hospital and clinic level, in order to maximize staffing efficiencies. And finally, onto our sources. For influenza death data, we got that from the CDC, so it is highly reliable. Its main limitation is that it was at the state level. So any flu severity data that is at a finer geographic level would help us with the next steps. The population data came from the census, so it is also highly reliable. It went down to the county level, but it was aggregated up to the state level to match the influenza deaths data for this analysis. Thank you very much, and let me know if you have any questions.